and management of a young male with bilateral bronchiectasis. So this was 10 marks question. So what it could be, which disease they want, anybody? See, basically they are talking about Young syndrome or something, but they have not given very clear indication because they have not mentioned sinusitis or any upper airway का issue. बस they have said ना ही azoospermia या कुछ नहीं बोला, बस young male with bilateral bronchiectasis. So you'll talk about Young's, but not only Young's. You'll talk about all the causes of bilateral bronchiectasis. It could be cystic fibrosis, it could be anything. But definitely, as the question says, young male word आने से फिर लगता है कि ये young की बात करे, but they have not given any other clue. They have not talked about that he was infertile. They have not talked about with the sperm count or anything. They have not mentioned that. Okay. So how would you approach? So answer would be the evaluation, and this is 10 marks question, so you have to be elaborative. The evaluation and management of a young man issue again today with the net item. Young male with bilateral bronchiectasis involve systematic approach to determine the underlying cause, to assess the severity of the disease, and to tailor the treatment to prevent further damage to lung and improve quality of life. It involves a systemic approach. First, you will say we'll talk about evaluation. How would you evaluate? The evaluation, first point will be history and physical examination. Presenting symptoms, chronic cough, sputum production, often purulent, recurrent respiratory. So what will be the symptoms of such a male? So we'll ask for this. Recurrent respiratory infection, it could be hemopsis, bronchiectasis patient. We need to assess the frequency and hello, are you able to listen? Sorry. Assess the frequency and severity of these symptoms. So these are the symptoms which the patient will usually present with. We have to assess the symptoms severity and frequency. After assessing the history and physical examination, we'll go for history we have talked about, then physical examination in this. Sorry. So after presenting symptoms, we'll talk about medical history. we'll talk about. So presenting complaints देख लेंगे. We'll assess the frequency of these complaints. We'll talk about medical history. In medical history, we need to ask him about childhood infection. In childhood infection like pertussis, pneumonia, measles, family history. Family history of what? Family history, you have to ask if there is any family history of cystic fibrosis, alpha 1 antitrypsin deficiency, anything like that, or any autoimmune condition. Then environmental exposure. We'll talk about environmental exposure like any smoking, any occupational hazard, any secondhand smoke exposure. We'll talk about past medical history, underlying condition like any past history of TB, any past history of connective tissue diseases. Then we'll ask about social history. Social history like any travel history. Okay. Then after this history part, we'll talk about physical examination. In physical examination, there'll be general examination. So you have to write all that. How would you evaluate? In general examination, you'll evaluate for if there is any weight loss, if there is fever. After general examination, you'll go for respiratory system examination. Respiratory system examination for if there is presence of crackles in the chest, or is there any added sound, wheezes, or signs of consolidation. After that, you'll assess for the systemic involvement. You'll assess for systemic involvement, like you'll look for clubbing. You'll look for cyanosis or signs of respiratory failure, if there is labored breathing or anything like that. So after physical examination, you can go for lab investigations. So history, physical examination, and third point will be lab investigation. In lab investigation, you will go for first CBC, complete blood count. That may show, sometimes they can be raised TLC. Okay, raised TLC, which can be that show indicative of infection. Then you will go for sputum culture, sputum GSCS. That will be to identify the colonizers as well as infective agent. Sometimes bronchiectasis patient will have colonizers like Pseudomonas or staph. Then you will go for immunoglobulin levels. Immunoglobulins level. We'll check for the deficiency of IgA, IgG, M, and E. Okay. And then we'll go for alpha 1 antitrypsin deficiency level. Then cystic fibrosis screening. That means you'll go for sweat chloride test. if it is suspected, or if you are suspecting any autoimmune disease, then you will go for autoimmune markers like ANA or rheumatoid factor, whatever. After third, was the lab finding. Then we'll go for imaging. During evaluation, imaging. In imaging, you will go for first of all chest X-ray. It will show the presence of bronchial wall thickening, tram track opacity, then cystic changes in the lung. Second will be CT chest. HRCT will go for HRCT. And what the HRCT will show? It will show, it is the gold standard for diagnosing bronchiectasis. First of all, it will show a detailed image, what it is, bronchial dilation, then lack of tapering, that is pathognomic for bronchiectasis, lack of tapering of the bronchus, then bronchial wall thickening, and mucus plugging. Okay. And fifth, we'll go for after imaging PFT, pulmonary function test. In PFT, spirometry will show us obstructive lung disease. And when we go for DLCO, it will be also reduced. Okay. This was about evaluation. Now we talk about management. The next part of the question was how will you evaluate and then management. So we'll talk about managing a young male. So first of all will be treatment of the underlying cause. It was just young male with bilateral bronchiectasis. So never discuss just young syndrome because they have not talked about azoospermia. They have not talked about. ऐसा नहीं है कि कुछ gender appropriate कुछ बोला है. So treatment of underlying cause. So you say cystic fibrosis अगर आता है cause, then genetic counseling and specific treatment like CFTR modulators, like any name, Eva, Taftor, chest physiotherapy, and cystic fibrosis. Besides all this, one very important thing is pancreas. So pancreatic enzyme replacement. Okay. अब अगर disease is not cystic fibrosis, but say the disease what we got is immunodeficiency, IgE deficiency. In immunodeficiency, we'll have to replenish the appropriate immunoglobulin replacement therapy. Third, it could be post-infections. Post-infection, then we have to give up, or due to infection, then antibiotics have to be given. If it is due to alpha-1 antitrypsin deficiency, then we have to replace alpha-1 antitrypsin replacement. So this was about treatment of underlying cause. Then second part in the management will be, this will be treatment of the underlying cause. Second part will be airway clearance. Because bronchiectasis, the problem is mucus is getting built up. So airway clearance. Airway clearance में क्या-क्या कराओगे? Chest physiotherapy. Most important, most effective. Chest physiotherapy would include what? postural drainage, then positive expiratory pressure, or we call it oscillatory positive expiratory pressure. That is OPEP device. OPEP device. They help in mucus clearance, or 3% NS inhalation. After airway clearance, we have third is pharmacological management. So here, antibiotics. In antibiotics, depending upon the bacteria which has been, we give inhaled antibiotics like tobramycin and of course pseudomonas. Then we give bronchodilators for patients for obstructive bronchodilators. Saba, Laba, Lama are given. Inhaled corticosteroids are given, and then mucolytics. Then fourth part for the management is management of exacerbation. Now, acute exacerbation of bronchiectasis would require prompt treatment, mainly with antibiotics and possibly short-term steroid. Okay. And if required respiratory failure में patient आता है, we might have to give O2 therapy. Then fifth point for management is surgery. When do we need to consider for surgery? In cases surgery bilateral bronchiectasis may not possible, only when it is unilateral. So depending upon involvement. So in our case, in this question, so surgery is not possible. You write in bilateral disease, surgery not possible. Sixth, long-term follow for management. You will mention long-term follow-up. Long-term follow-up. In long-term follow-up, you have to go for vaccination. You have to go for lifestyle modification and regular monitoring.